Support call. During this webinar, CMS will provide an overview of 2019 CMS Web Interface quality reporting for MIPS groups and ACOs. After the webinar, CMS will take as many questions as time allows. So now I'll turn it over to Sandra Adams-Slaughter from CMS to begin.
Thank you, Michaela. Welcome, everyone, and thank you for joining us today for the CMS Web Interface quality support call. I'm Sandra Adams-Slaughter from CMS. Joining me today on the call are other CMS experts and contractors who will share helpful information on CMS Web Interface quality reporting and answer your questions during the question and answer session after today's presentation. Today's call will only focus on quality reporting. You can contact the Quality Payment Program Service Center with any of your questions regarding cost, promoting interoperability, improvement activities, MIPS, or quality reporting in general. Next slide, please. And this is our disclaimer slide about the presentation. Information in this presentation was current at the time it was published. I urge you to please be sure that you are using the source documents and links that are provided throughout the presentation. And please stay tuned to any communication from the Quality Payment Program, Medicare Shared Savings Program, or Next Generation ACO model regarding any updated information. Next slide, please. This slide shows that previous support call sessions are now available. The recording slides and transcript for the January 29th support call are now available on the Quality Payment Program library. Next slide, please. On this slide, you will see some submission period key dates. The submission period for the CMS Web Interface aligns with other submission types for 2019. The submission period opened on January 2nd, 2020, and will be closing at 8 p.m. Eastern Daylight Time on March 31st, 2020. Your submission will be automatically accepted at submission close. As a reminder, the CMS Web Interface is using the sign-in link on the Quality Payment Program website, which is circled here. Next slide, please. This slide has some more announcements for upcoming CMS Web Interface support calls. Today's webinar is part of a series of web interface support calls held weekly throughout the data submission period. The next support call will be held next Wednesday, February 19th from 1 to 2 p.m. Eastern Standard Time. Topics will include frequently asked questions on measures PREV 7 and PREV 10. Next week's support call will be primarily question and answer. And also, additional topics could possibly be added prior to the next support call. Next slide, please. And this slide has some reminders. First, the other CMS-approved reasons skip requests must be submitted through the CMS Web Interface. This is a way to skip patients attributed to a measure during denominator confirmation. The CMS-approved reason is reserved for circumstances that are unique and unusual and not covered by any of the denominator exclusions or denominator exceptions identified in measure specifications. Patients for whom a CMS-approved reason is selected will be skipped, and another patient must be reported in their place for the measure if available. Next slide, please. So the 2019 CMS Web Interface Application Programming Interface, or API, is available all year for testing in the developer preview environment. You can review the resources listed on this slide for more information. Next slide, please. And now Angela Stevenson will talk about some frequently asked measure questions.
Hi, everyone. This is Angie with the PIMS Measures team, and I have just a few questions to share with you that we've received recently. For the CARE 2 measure, the question is, the specification states a clinician with appropriate skills and experience may perform the screening. Would a nurse outside of the office be considered a clinician? The answer is yes, a nurse with the appropriate skills and experience may perform the screening, and the setting is not restricted to an office setting. Question for hypertension measure is, can a hypertension diagnosis be found from an urgent care or emergency room record, or does it need to be from a PCP office visit? And yes, medical record documentation from urgent care or emergency room may be used to confirm the diagnosis. Again, the setting is not limited for the diagnosis identification on that measure. For the PREV-7 measure, clinician document patient refusal of the influenza vaccine by using the Z28.21 influenza vaccine decline diagnosis code. It is not included in the CMS Web Interface PREV coding document in the Denominator Exception codes. The answer is yes. Although the particular coding question is not contained in the document, a patient refusal documented in the medical record would be appropriate documentation. Documentation should be during the measurement period and be specific to the flu season being reported. For the PREV-10 measure, we have a question, is the numerator met if a patient is identified as a smoker during the most recent screening, was not counseled, but had counseling previously within the reporting period? The answer is yes, as long as there is documentation that cessation intervention occurred within the 24-month look-back period, that would be acceptable. Thank you, and I will pass it back to Sandra Adams-Slaughter with CMS.
Thank you, Angie. Next slide, please. So this slide contains some resources. Please note that 2019 materials providing information on MIPS quality performance category are available on the Quality Payment Program Resource Library webpage. We encourage reviewing these resources if you have questions on quality requirements and measures. We'll continue to communicate these resources in any future postings in upcoming support calls. Next slide, please. So this is a reminder that the QPP webinar library also contains recordings, slides, transcripts for past Quality Payment Program webinars, including the recent 2019 Web Interface user demonstration held in November, and the CMS Web Interface kickoff call held last December. The recordings, slides, and transcripts for January 15th, 22nd, and 29th calls are also available in the library. Please note that it may take 1 to 2 weeks to post the presentations to the library following a support call. Additionally, the Help and Support page on the Quality Payment Program website contains links to materials such as videos, webinars, and online resources, as well as other items to help with reporting and development. Next slide, please. Again, some additional resources, the Medicare Shared Savings Program and Next Generation ACO website links are on this page. Next slide, please. And if you need additional assistance, please refer to the contact information listed on this slide to get the help that you need. Next slide, please. Now, just before we move into the question and answer portion of this call, if you're interested in providing feedback and collaborating with CMS on the quality payment program, we encourage you to participate in our human-centered design efforts. To get involved, please email your name, title, topic of interest, and organization to the web address on this slide. And now I will hand things back over to Michaela to begin the question and answer period.
Great, thank you, Sandra. So we will now begin the question and answer portion of this webinar. So please do submit your questions via the questions tab on your screen, or you can raise your hand and we will unmute your line. So our first question is on Prev 6. If any patient had a colonoscopy within the past 10 years and they're compliant, but the report results state a recommendation to have it done again in 5 years, and they say not compliant due to not repeated in 5 years, and the date is 7 years ago, do I mark that person as a yes, had a colonoscopy in the past 10 years, or no, because of the 5-year recommendation which they missed?
Hi, this is Angie from the PIMS team. The measure is not tracking patient compliance to the clinician's recommendation. So if you have medical record documentation that supports the colonoscopy was performed during the measurement period or the 9 years prior to the measurement period, then you may select yes. Thank you.
Thank you. Our next question asks, if a patient is 76 or older, are they still excluded from Prev 13?
And this is Deb from the PIMS team. I believe we were able to provide an answer to a help desk question on this one, and that response hopefully was received, and that is the denominator population 3 is limited to patients aged 40 through 75 years at the beginning of the measurement period. So if a patient is out of the measure's age range, it would automatically pre-populate the response with not confirmed age. Thank you.
Thank you, Deb. Our next question is on Care 2. Can we count mobility screening or disability screening as a yes? And they say, for example, the mobility screening has the following question. Do you have serious difficulty walking or climbing stairs?
Hi, this is Olga from the PIMS team. Screening for future fall risk is defined within the measure specification as an assessment of whether an individual has experienced a fall or any problems with gait or balance. There must be documentation in the medical record of a falls risk screening that includes the patient's history of falls, a described fall, a note stating no falls, or an assessment of gait or balance during the measurement period. Also, please note that the medical record must include documentation of the screening performed. Thank you.
Great, thank you. So now we'll take a question from the phone line. So Yamini Shah, I've unmuted your line. Please go ahead with your question. Yamini Shah, we've unmuted your line. Please go ahead with your question.
Hi, can you hear me?
Yes.
Hi, I had a question. If a patient is having depression since 2012, but not a major depression, just a depression, and the patient has to be like submitted for MH1, will that patient qualify as dysthymia?
Hi, so this is Katie from the PIMS team. So in order to confirm the diagnosis for MH1 for the patient, you would need a diagnosis code on the account or problem list, and those applicable codes can be found within the MH1 coding document along with the measure specification. So we'd encourage you to take a look at that. In addition, the words major depression, major depressive disorder, dysthymia, dysthymic disorder, and pervasive depressive disorder on progress notes or problem lists can be used to confirm the diagnosis. So additionally, in paper records, the description of depression may be used with the option to confirm by billing code. So you would need to confirm that it's the appropriate diagnosis for the measure and have the appropriate supporting documentation. And if you have further questions, I would suggest perhaps submitting that question to qpp@cms.hhs.gov, and we can take a closer look at it for you as well. Thank you.
Thanks.
Great, thank you. All right, our next question is on Prev 7. This person says, on last week's call, someone asked if a patient declined just before the start of the official flu season, and they say July 2018. Do they have to be asked to decline again during the flu season? And they say that the response was no. Can you please clarify?
Hi, this is Jamie from the PIMS team. Thanks for this question. That decline would have to be attributed to the current flu season. So the current flu season would be represented by, October to March, which would be then September to December of 2018 and January to March of 2019. Now, they are able to go ahead and look back to August to see if the patient declined, but it would have to be somewhere within that time frame. And you can find that time frame within previous receipt definition of the measure specification.
Great, thank you. Our next question says that the 2016 GPRO Web Interface Q&A states on page 26, question 16, can state registry be used as an extension of the medical record? And this person notes that the answer says if the information is available at the point of care, then yes. So they're asking, does this answer apply to the 2019 reporting period? And can you describe what available means?
Hi, this is Jamie, again, with the PIMS team, and just want to thank this questioner for going ahead and asking the question to verify that things haven't changed for the current year. So applaud you on that. Thanks so much for doing that. You can still use the state registry to determine, just ensure that the medical record, this piece of the medical record documentation, again, is attributed to that current flu season. Thanks.
Great, thank you. Our next question's on Prev 13. Is COD a diagnosis that we can use?
So this is Deb from the PIMS team. I would encourage you to look at the coding that is available in the coding document for PREV, and you can sort that so that you can look at PREV 13 specifically and see if what you are finding in your medical records matches the intent based on the coding that's been provided. Thank you.
Thank you. All right, we will take another question from the phone at this time. So, Michael Levant, I've unmuted your line. You may go ahead with your question.
Hi, thanks. This question is in regards to PREV 7 as well. If there's documentation in the EMR that the patient is refusing all preventative vaccinations or all vaccinations, is that sufficient to as a denominator exclusion?
Hi, Michael. Thanks for the question. This is Jamie with PIMS. The documentation is going to have to indicate that it's specific to flu. So if you can find somewhere else within your medical record or reach back to clarify that would probably help you out. But otherwise, yeah, somehow it has to point back to the flu vaccination. Is that helpful?
Yes, thank you.
Okay.
All right, our next question comes from an ACO, and it's about PREV 7. They're asking, would notation in the medical record of immunizations declined be sufficient for denominator exclusion for patient reasons?
So again, as long as, this is Jamie with PIMS, as long as that medical record documentation is applicable to the flu vaccination within that measurement time frame, which we talked about, that August to March respectively, then that documentation appears to suffice for the measure.
Great, thanks, Jamie. All right, our next question asks, does intolerance to atorvastatin meet exception criteria for Prev 13, or does intolerance need to be documented for all statins?
So this is Deb from the PIMS team. You don't have to document for all statins. What you do have to do, though, for the denominator exception is ensure that it is active during the measurement period. So if you had documentation of intolerance to a particular statin as the reason why a statin was not prescribed in 2018, that wouldn't be sufficient for the 2019 program period because it has to be considered active during the measurement period as a reason why a statin wasn't prescribed. Thank you.
Great, thank you. All right, we'll take another question on the phone at this time. So Stacy Hubert, I've unmuted your line. You may go ahead with your question.
Hi, everyone. I'm calling about Care 2. I just wanted to get a little bit more clarification on the spec. Is gait synonymous with walks? In our documentation, we have questions as how much difficulty do you have walking a quarter of a mile, or do you have any difficulty walking across the room? So I want to make sure that we could take credit for that, making sure that gait equates to walk. That's the same meaning.
Hi, this is Katie from the PIMS team. I would suggest in this instance to submit your question to the Service Center, and we can take a closer look at that for you. So if you can submit that to qpp@cms.hhs.gov and indicate your question is for 2019 Care 2 reporting for the web interface, we can examine that further for you.
I did already, unfortunately, and I got the specs. They just reiterated the specs. So I was hoping that you guys can help me out and get a little bit more clarification on it.
Sure, and in these instances, we're not able to comment, further on making that interpretation for the spec. So it would be up to your organization to determine if your documentation meets the definition within the measure specification.
Okay.
Okay, thank you.
Thank you.
All right, thanks, Katie. All right, our next question says, in a previous webinar, a speaker mentioned that we could go to the next OP encounter if the most recent blood pressure was from the emergency department for HTN2. Can we do the same if the most recent blood pressure was from the inpatient setting, since this measure is intended for the outpatient setting?
Hi, so this is Katie for the PIMS team. So for 2019 reporting, that is correct. So since the measure is intended to be outpatient, it would be appropriate to move to the next most recent blood pressure if the most recent from an ED or inpatient setting is not within normal parameters. And just to add a bit of clarification to that, you're not required to use blood pressures from those settings, but since the measure is not restricted to a setting, you can, but move on to the next most recent if it's out of control. So I hope that helps clarify. Thank you.
Thank you. Our next question is on Prev 13. This person says, I have a patient that has a diagnosis of diabetes and has an Ldl of less than 70, but is on a statin. How do I document this patient?
This is Deb from the PIMS team. That LDL less than 70 is a denominator exception. And so for a denominator exception, if you find that the patient is on a statin, you can report that the patient is on a statin. Those exceptions you'll find There are times that the quality action is still appropriate for a particular patient, and you do not have to select the denominator exception, which is different than a denominator exclusion. If you find that a patient meets the denominator exclusion criteria, you have to select the denominator exclusion because those patients were not intended to be part of the patient population for a particular measure. So again, if you find that the patient meets the criteria of the patient population 3 for Prev 13, but has their most recent or direct LDL-C lab test was a result of less than 70, but they are taking a statin, you can select that they are on a statin. Thank you.
Thank you. All right, our next question asks, what should an ACO do to reconcile demographic discrepancies? And they list as an example a patient matching on HICN, MBI, and name is a match with the EMR, but the date of birth is 1 year off. And they say that the practice has a photocopy of the license with the date of birth that does not match CMS files.
Hi, this is Amy Mills with ACO PAC. So we would encourage you to update that information in the web interface, and just note that any demographic information that you do change in the CMS web interface does not get reported back to the Medicare beneficiary enrollment database. So you should encourage that patient to contact the Social Security Administration directly to have the information updated.
All right, thank you. And at this time, we will take another phone question. So Theodora Mosseri, I've unmuted your line. You may go ahead.
Hi, can you hear me?
Yes.
Okay, thank you. So my question has two parts, and it's for the mental health measure. So for the PHQ-9, do you have to see all 9 questions, or would it be sufficient to see the name of the tool and the summary score? That's the first part. And then if you do happen to see all 9 questions and you do not have a valid summary score, can you add it up yourself to get the score? Thank you.
Hi, this is Katie from the PIMS team. So to answer your first question, the measure specifications do state that you need to have the name of the tool and the summary score. There's not a requirement that you need to have a copy of the completed PHQ-9 or all questions. In terms of your second question, I think it kind of ties in that valid summary score is required. So if it's not documented, we wouldn't be able to accept it. But I think we would like to take a look at this question further for you. So if you could please submit this inquiry to qpp@cms.hhs.gov, we can investigate and clarify a little further. Thank you.
All right.
All right, thank you. So this next question asks, how is Prev 7 answered if the patient comes into the office and has already been sick with the flu this flu season?
So this is a good question too. And if it's felt that the patient didn't receive the flu shot for a medical reason, then it would be appropriate to do so. But again, you're going to have to go back to that medical record, make some considerations about the circumstances surrounding that situation. Thanks.
Thank you. All right, our next question asks, for tobacco cessation, can the counseling be performed by any team member in the clinic?
Hi, this is Jamie again with PIMS, and yes, any team member can go ahead and do that screening and cessation. The measure does endorse a team approach to doing this and having this interaction with the patient. Thanks.
Great, thank you. All right, and our next question is also on tobacco cessation. Could you please review when tobacco cessation is to be completed? And they note that page 11 of the guidance under the notes states, and the cessation intervention must occur during or after the most recent tobacco user status is documented. And then they say, if a tobacco screening is completed on December 31st, 2019, and the patient is a smoker and was not provided with tobacco cessation on that same date, but cessation counseling was previously provided on February 10th, 2018, would this be a numerator yes?
Hi, this is Jamie with the PIMS team. I just want to say thanks for asking this question because it is something that I followed on not too long ago. There are new specifications or an updated, let me say it this way, an updated specification is posted for 2019 it's going to give you and coincide with the response I'm about to give. So go on out to the QPP resource library and check out those specifications and just make sure you're referencing the most current versions. And then in response to your answer, that February date would still count because it's within that 24-month period. And so once you do this, you have the screening, the cessation just has to be done within a 24-month period for that patient. So again, go ahead, take a look at the updated specifications out on the QPP resource library page, and hopefully that helps close the gap for you. Thanks so much.
Thank you. All right, we'll take another phone question at this time. So Rachel Leap, I've unmuted your line. You may go ahead with your question.
Yes, the question is about the mental health measure again. If you have a patient who has a long-standing diagnosis that is on the list of the codes, but you can't find a PHQ which is positive in the time frame, what do you do?
Hi, this is Katie from the PIMS team. So in order to confirm the patient in the denominator for the MH1 measure, both components must be met. So first, you have to, like you said, determine if they have the appropriate diagnosis within the denominator identification period. But then secondly, you also need to determine if they had a PHQ-9 or PHQ-9M greater than 9. In that denominator identification period as well. So if there's no medical record documentation that the patient was administered that PHQ-9 within that denominator identification time frame, you would answer no to that question, whether or not they had one. And then if the answer is no, the patient will be skipped and another patient should be submitted in their place.
But if the answer is yes, that they had the screening done but scored 0.
Sure. So the denominator confirmation requires that the score is greater than 9. So that question will ask, did the patient have a PHQ-9 or PHQ-9M score greater than 9? And in this case, since the score was 0, you would answer no to that question.
Okay. Okay, thank you.
No problem.
All right, thank you. And I'm seeing some follow-up questions on the question we had earlier about the statin and the patient with diabetes who had an LDL less than 70. Can you count the statin for that?
So hopefully I understood the question. Yes, if a patient meets denominator criteria for the patient population 3 for the PREV13 measure, even if they have an LDL that is less than 70, if they are on a statin, you can submit that they are on a statin, which is included, and let me find the right page real quick. If you look at the posted measure specification, page 6, I believe the denominator exception reads, patients with diabetes who have the most recent fasting or direct LDL-C laboratory test result less than 70 and are not taking statin therapy. So if they're taking statin therapy, they would be considered a performance met. If they're not taking statin therapy and you've made it to the population number 3, you can select that exception when they're not taking a statin therapy. Thank you.
Thank you. All right, our next question's on Care 2. Could we use the fall risk assessment completed in the inpatient or emergency room? They note that the inclusion E&M does not list the ED or inpatient E&M codes.
Hi, this is Olga from the PIMS team. The measure does not limit the type of setting. The enumerated guidance in the measure specification states that the setting of the screening is not restricted to an office setting. For EHR mapping, the coding that's provided within the care coding document would be considered to be all-inclusive.
Thank you, Olga. So going to our next question. So this person says that someone had a question about HTN2, if it was high, inpatient, or in the ER. The answer was that we could take the next reading. Did you mean the previous reading in 2019 or the next one in January of 2020?
Hi, this is Katie from the PIMS team. So the hypertension 2 measure is for blood pressures during the measurement period. So if the most recent one is late in 2019, then you would look back within the measurement period to perhaps an earlier visit to find a blood pressure in an appropriate setting for 2019. Thank you.
Thank you. All right, our next question asks, could you please repeat what you said about an allergy to a statin? Does it have to be all statins, or can it be an allergy to one specific statin?
So this is Deb from the PIMS team. It does not have to be an allergy to all statins. I would point you to page 14 of the posted specification, though. So if you're mapping to an EHR when an acceptable drug allergy is found, you would look for the drug classification with a yes conditional. These drugs may be used as a denominator exception if present in the patient's record, accompanied by an appropriate conditional reason why the patient isn't taking the drug. So an adverse effect, allergy, intolerance to statin medication. The only thing to be aware of is a little further down on that same page, the denominator exception must be considered active during the measurement period. So that the fact that a patient might have documentation that they were allergic to one particular statin, say back in 2017, and that's why they were not prescribed a statin, would not meet the requirements for the 2019 program period unless you have documentation that supports that denominator exception is active during the performance period. Thank you.
Thank you. All right, we'll take another phone question at this time. So Carlos Rios, I've unmuted your line. You may go ahead.
Hi, good afternoon. I wanted to clarify something in one of the slides presented today, slide 9, regarding Prep 10. There was a statement about if the documentation that cessation intervention occurred within the last 24 months look-back period, even though the last screening was positive, that would still count. This is something that was reversed 2 years ago, but can you please confirm that the measure changed again?
This is Deb from the PIMS team. So you are correct. There was a guidance change. So starting in 2019, you'll take the most recent screen. You can look back a total of 2 years, the measurement period of the year prior for the cessation intervention.
Okay, thank you for confirming.
Thank you.
All right, and I think the team has a clarification they'd like to share on MH1. So Katie and team, I'll pass it back to you.
Thank you. This is Katie. I just wanted to clarify that for the PHQ-9 or PHQ-9M screening, you do need to, all 9 questions must be answered to have a valid summary score. So in these instances, if a patient chooses more than one response for a single question, you would select the worst response to calculate the summary score. The piece that I was intending to clarify, but maybe didn't do it justice, is that your documentation just must support that all 9 questions are answered. They're not specific requirements within the measure specification as to what that particular documentation looks like, whether it's a copy of the completed PHQ-9 or documentation that it was completed, all 9 questions are answered, and you have that valid summary score. So I just wanted to clarify that you do have to answer all questions for that valid score. Thank you.
Thank you. All right, our next question is on Prep 6. If there is documentation of a colectomy in an office visit note on a certain date, but does not specify if it is a total or a partial, can this be used as an exclusion? And this person says they're unable to find a surgical note on the procedure to confirm if it is total or partial.
Hi, this is Angie with PIMS. The denominator exclusion in the measure specifications does state that it has to be a total colectomy. You may want to work with the eligible clinician to see for clarification on the specific documentation that you have. You can also refer to the 2019 PREV coding document in the denominator exclusion codes. There are procedure codes that can help you find information within the medical record, perhaps, to support the type of colectomy that was done. But the specs do say it has to be a total. Thank you.
All right, thanks, Angie. So our next question asks, is palliative care and hospice considered the same?
Hi, this is Angie with PIMS again. Not quite. Palliative care is non-hospice care. It's meant to improve the quality of life of patients with serious illness. But for the purpose of the CMS Web Interface measures, if you have medical record documentation that the patient received palliative or comfort care anytime during the measurement period, then you may select not qualified for sample and use the in-hospice reason when reporting that. Thank you.
Thank you. All right, we'll go back to the phone for another question. So Jason Simones, I've unmuted your line. You may go ahead.
Can you hear me?
Yes.
Okay, great. Thank you. So this question is related to PREV 12. So I understand that for this year, previous specifications are allowed, right? What we've been able to report for previous years is allowed. So this question is really about moving forward. So in every year prior, PHQ-2 has been acceptable for the screen, and if positive, a PHQ-9 has been acceptable for the follow-up. I had asked this question, sent it in to the QPP email address to get confirmation that this would still be the case moving forward in 2020, and the response was that it would not be appropriate to have the PHQ-9 be the follow-up. So my question is, one, is that correct, and if so, why? Because I don't believe that has been talked about at all in any of the changes that you guys have kind of laid out with the PREV 12.
So this is Deb from the PIMS team. I do know that the information you've been provided is accurate, and my understanding is that is tied to a coding change that occurred. And so if you look at the SNOMED code that was removed, that SNOMED code that was removed is what allowed the PHQ-9 to be considered the recommended follow-up, and if completed on the same day as the positive PHQ-2, kind of allowed that scenario to happen. But in 2019 and in 2020, that SNOMED code is not available, and that is what changed that ability to select a PHQ-9 as the recommended follow-up.
So the follow-up question for that then would be, I mean, you guys have kind of stated that the coding document is used for mapping to the EHR. So if codes aren't there, but in the description things are there in the medical record, that's allowed. So how is this different?
Because that coding change, that changed the measure itself. So that particular coding change changed that logic. And I would just say if you have more 2020 questions, we can certainly take those through the help desk and provide additional information. But so that we can answer the 2019 questions, it might be better to do that and then take that 2020 question through the help desk.
Thank you.
Thank you.
Great, thank you. So we have another follow-up question on the PREV 13 risk category 3 scenario. So this person's asking if the patient has diabetes but does not have an LDL less than 70 and the patient is on a statin, did you say that we can accept that, and do we answer yes to the risk category 3 question to get the patient confirmed into the measure?
So this is Deb, and I would recommend for sure, because this PREV 13 can get a little bit convoluted with the 3 different patient populations. So I would refer back to the specification, both the text and even the measure spec flow. You should be going through this measure, stepping through it based on the population. So if you have answered no to risk category 1, where the patient had the ASCVD diagnosis, then you answer no to does the patient have a direct lab result greater than or equal to 190 or were previously diagnosed with specific diagnoses, and you've got to your patient population number 3. If that patient is of the right age and you have confirmed that they have diabetes with an LDL-C result of 70 to 189, you're going to confirm that they belong in the denominator. Once you've confirmed that they are denominator eligible for that risk population number 3, it's at that point you should be able to select your denominator exception. So I have a patient that is eligible, they meet the denominator criteria, but let's say that same patient has a most recent fasting or direct LDL-C of less than 70 and they're not on a statin, you can select the denominator exception. But if you find that that patient does have an LDL-C of less than 70 and they're on a statin, you can select that the patient is on the statin. I hope that clarifies. Thank you.
Great, thank you so much. So this next question asks, is there a benefit or a detriment to reporting on more than the required 248 patients? For example, doing all 600? Hi, and again, that question was, is there any benefit or detriment to reporting on more than the required 248 patients? For example, doing all 600?
Hi, this is Lisa Marie. So your ACOs and groups are required to report on a minimum of 248 consecutively ranked beneficiaries. If you report on more, I mean, it's not necessary. It won't change or impact how well you do in terms of, like, the more you report, the better. Like, just by reporting more, it's going to increase your score. It's not necessary. It's not necessarily the case. So we just encourage folks to report on at least 248 consecutively ranked beneficiaries, in which, meaning that if you haven't skipped any, if you skip any beneficiaries, you will have to report on more, but in total, you just have to report on the required of 248 consecutively ranked beneficiaries.
All right, thank you, Lisa Marie. So now we'll take another question from the phone. So Yvonne Barrios, I've unmuted your line. You may go ahead.
Yes, hi, good afternoon. My question is related to ACO 43. ACSC, and wondering if in year 2 and 3, if it's a reporting or performance measure. We showed it as performance, but through recent information that I reviewed, and I'm sorry I don't have it in front of me, it shows it as reporting. So can you please clarify?
Hi, this is Fiona from the Shared Savings Program. For 2019, ACO 43 is pay for performance. It only changes to pay for reporting for 2020, and that was finalized in the CY 2020 physician fee schedule.
Okay, thank you. In terms of the information that I read that has caused confusion, would I just send that for review to the next gen ACO email address?
Yes, you can do that.
Great. Thank you. I appreciate it.
All right, thank you. So going to our next question, and I believe we touched on this some earlier, but there's another question on MH1, and it says that the measure specs state the following. Additionally, in paper records, the description depression may be used with the option to confirm by billing code. And the person asks, does this apply to EHRs as well? If the word depression is found in the EHR, would that be sufficient for confirming the diagnosis?
Hi, this is Katie from the PIMS team. So I think this is somewhat similar to the question that we had earlier. So the measure specifications do provide additional guidance on how to confirm that diagnosis and what language specifically to look for within your medical record documentation in order to confirm an appropriate diagnosis. So the word depression alone is not sufficient to confirm the denominator. We would suggest taking a look at the coding document and any of those other words within the measure specification that would be appropriate to confirm the denominator. Additionally, I do want to add that the diagnosis must be active during the denominator identification period. So that means a diagnosis that's either on the patient's problem list, a diagnosis code description listed on the encounter, or is documented in a progress note indicating that the patient is being treated or managed for the disease or condition during the denominator identification period. So again, just to reiterate for this specific question, the word depression alone is not sufficient, and we suggest taking a look at the MH1 coding document as well as the measure specifications listing of appropriate language within your medical record documentation. If you have further questions, please submit those to qpp@cms.hhs.gov and we can try and further clarify for you. Thank you.
Thank you. All right, our next question is on Prep 7. If the provider states that during the measurement period, the patient has had the flu shot this flu season, but doesn't list a month, are we required to fail the case?
Hi, this is Jamie with the PIMS team. We were doing some research on this, and it does look like a month needs to be provided with that flu shot in order to meet numerator compliance. So if you could scour that chart and possibly try to find a month within the flu season where that was administered, that'd be great, or maybe a previous receipt. Otherwise, it looks like you may fail the measure. But if you want to submit a ServiceNow help desk question or ticket, please do so. Thank you.
Great, thank you. All right, it looks like we have time for about one more question. So this one's on Prep 5. They say on last week's call, we received direction that the BCS measure requires a bilateral mammogram in a woman with 2 breasts. If this woman has an abnormal bilateral mammogram and a series of unilateral mammograms for follow-up, are we only to use the bilateral mammogram to determine numerator compliance, or should we use the date of the last unilateral mammogram to determine numerator compliance?
Hi, this is Angie from PIMS. The intent is to use your bilateral mammogram screening, and so if it was in the measurement period or the 15 months prior to the measurement period, then I would stop there and select yes, because that is bilateral is the intent. If you're not finding one and you have 2 unilateral within that time period, then you could use those and select yes. Thank you.
Thank you. And I'll just pass it back to the team. I think there might be some clarification on the response about reporting the whole sample rather than the 248 beneficiaries. So did you all have anything else to add there?
Hi, this is Azam. I just would like to add that if you report on beneficiaries in your oversample that is above the 248, as long as you consecutively report the beneficiaries in the oversample, it will be included in your performance calculations. So it could increase or decrease your score based on the data reported. Thank you.
Great, thank you, awesome. So that is all the time that we have for the Q&A today. And I am pulling up here again this slide on getting help from CMS, so of course feel free to contact CMS through these email addresses if you have additional questions, and then I'll pass it back to Sandra Adams-Slaughter to close out the call.
Thank you, Michaela. Thank you, everyone, for joining us today. The slide deck, recording, and transcript from today's call will be available on the QPP webinar library in the next 2 weeks. As a reminder, our next support call is scheduled for next Wednesday, February 19th from 1 to 2 p.m. Eastern Time, during which we will cover assignment and sampling frequently asked questions, as well as frequently asked measure questions regarding PREV 7 and PREV 10. We hope you'll join us. Thank you.